Thank you very much, Helena, and you'll see in the panel discussions that the EGC are integral to the whole of this meeting, as they are indeed to the way in which UK Biobank is being run. So I'm just going to kick off by giving a little background to what information we obtained at the beginning, and then during this next session, some of the many researchers who've contributed to enhancing UK Biobank will go into greater detail. So you may have seen on the program that we're kind of talking about our 10-year anniversary from when the first participants were recruited in the initial pilot phase and then into the main phase between 2006 and 2010. So just over 500,000 men and women from across the UK aged 40 to 69 at that time. There's been some earlier discussion about the consent. So there was general consent for all types of health research, and this was another topic that was discussed in detail and through public consultation before UK Biobank went ahead as to specific research versus general consent for all types of health research, which is the way Biobank went forward, as well as recontact for particular purposes, provided it didn't involve feedback of information to an individual that they didn't know already, so not feedback of genetic information or anything like that. And one of the topics that came up in the earlier panel discussion, and that was it's been an issue that we've really considered, is how much recontact? Too much recontact? Too little recontact? How to recontact? So with respect to web-based questionnaires, which are very low cost, if we email out to participants, then we can get information for those individuals. But for individuals for whom we don't have email addresses, we have them for about 1/3 of the participants, sending out things by mail, by non-email, adds cost. And so our web-based questionnaires have focused on those that we can email to. Is that an appropriate strategy? As I'll just describe very briefly, at that baseline visit, there were a very large number of questions and measurements and biological samples. And then later in the day, we'll talk about the follow-up through linkage to health records, as the consent said, to medical and other health-related records, which again touches on this topic about what kinds of records are health-related, are they socioeconomic, are they tax, and also what is a record, does that include tissue? And importantly, and perhaps one of the most difficult messages to get across, is that our job is to build it with the input of researchers, as I say, from across the UK and internationally, for other people to use. There is no exclusive access, there is no preferential access, although that is bizarrely the most difficult thing for many people to understand. And the number of times I've talked about UK Biobank and then someone has asked me, can we collaborate with you? And I've said, no, the data are yours. You have to think of this as your resource. So we invited some 9 million or so people to take part in UK Biobank, and 500,000 took part. So it's not a random sample. We can't use UK Biobank to work out whether or not we'll be in Europe next month. But we have large numbers of individuals from many different walks of life. Younger individuals, older individuals. We have people from socioeconomic, more or less deprived, from different geographic areas, and a good proportion from various ethnic minority groups. And so the importance, the key aspect of UK Biobank is not that it's a representative sample of the UK. It isn't. The people who've taken part in UK Biobank are very particular, in the same way that blood donors are very particular. They are donating to a research resource. But by having large numbers of different kinds of individuals with different kinds of exposure, we build a generalizable resource about the importance of different risk factors for disease. We asked lots and lots of questions. It took nearly an hour for people to answer the questions onto the touch screen during that baseline visit, followed by a relatively short interview about some specific types of questions that are more difficult to do through touchscreen, particularly around medical history and medication. Information, though, that we can enhance by linkage to the medical record systems themselves, because not only do they allow us to find out about things that occur in the future, they allow us to find out about things that happened in the past by linkage to past medical records. And if you want to look at the detail of each of the questions, what the range of responses were for each question, then you can look at that on the UK Biobank website. The physical measurements were more limited in terms of the range of things that were measured on all 500,000 people, kind of standard risk factors such as blood pressure, measures of how thin, how fat, shape, lung function, bone density with HeLa ultrasound. But then, again, there were a number of groups that came up with ideas in which we could get more information about subsets. So the Medical Research Council hearing unit devised a hearing test that could be incorporated. Moorfields Hospital and groups working with them in the eye area, which we'll hear about later, came up with ways in which we could get more information about vision. And the MRC unit in Cambridge helped develop an assessment of people's fitness. And then even before Biobank started, there were a whole series of different studies done by researchers around the UK particularly, looking at what samples do we collect, how do we collect those samples, how do we process those samples, how do we ensure that over long-term storage we will be able to measure the things that people will want to measure in 10, 15, 20 years' time. So a very large number of pilot studies to determine what samples to collect. We collected about 55 mils of blood, about 3 tablespoons of blood, into different tubes, all separated and stored in different areas, as well as urine and saliva. And then as the project was running smoothly in terms of recruitment, we've been thinking about, well, what else? So there's been some discussion about the web-based questionnaires. And 100,000 to 200,000 people have given us detailed diet diaries. And as was discussed in the panel discussion, we wanted to know not what you wanted to tell us you would like to have eaten, but what you did eat yesterday. So for that questionnaire, we did say, we want to know about yesterday. And if you tried to wait until you'd had a better diet, it didn't allow that. But certainly the other questionnaires we need to tweak to make sure that people can spend more time on giving us information about occupation. We're sending out questionnaires to get more information about cognitive function, but we're also incorporating the cognitive function assessment into the imaging visit so that we have cognitive function at the same time as the imaging. And a series of other web-based questionnaires are being rolled out around mental health, around pain, around gastrointestinal issues, things that can't get either give us more information about the participants or more information about diseases that may not be well picked up through health record linkage. We'll hear about the extraordinary data that can be extracted from the wrist-worn accelerometers by Soren Bragg, and also about the genotyping. So I think when all of us started UK Biobank, none of us imagined that we would have genotype data on 500,000 people this soon in the project, and yet we will be releasing those data on all 500,000 in about September of this year, having released the first 150,000 last year, and many of the research projects that have been published have used those data already, and we'll hear about those. And currently, the laboratories in Stockport, where the coordinating centre is based, have been doing a standard panel of assays on the urine, looking at salts in the urine particularly, creatinine, and also in the blood samples, looking at markers of diabetes, at lipids, metabolic markers, some markers related to risk of cancer. And those data will start to get released during this year and later next year on all 500,000. And then finally, we'll hear in more detail about the imaging, the magnetic resonance imaging of the brain, the heart, the body, the low power radiation for looking at bone and joint as well as body, and carotid ultrasound that looks at the furrowing up of the artery, plus a repeat of the baseline assessment so that we can look at change over time since 2006 to 2010, and we can look at the association between measures in those baseline assessment and the imaging measures, in particular, very much more detailed cognitive assessment during that repeat assessment. So that's really what we did do in 2006, 2010, and some of the things that we're starting to do. And I'd like Soren Bragg now to come up and talk about what's he done, or what have the team done with the activity monitoring data, and why does it matter or not matter that someone wore their activity monitor at Christmas? Soren.